Good evening, everyone. My name is Dr. Amar Swahi, and I am a consultant physician and nephrologist working with the Sri Hindu Mandal Hospital in Dar es Salaam, Tanzania. It is my pleasure to welcome you all to the Africa Healthcare Network Fireside Chat Series number 124. We would like to thank the KDIGO, the Kidney Disease Improving Global Outcomes, for collaborating with AHN for the talk this evening. And it is my absolute honor to introduce our speaker for today. Professor Roberto Pecoits-Filho is a senior research scientist at the Arbor Research Collaborative for Health in the US and a full professor of nephrology at the School of Medicine at the Catholic University of Paraná State in Brazil. Professor Pecoits-Filho's research is focused on chronic kidney disease, and he's currently a visiting researcher for the George Institute for Global Health in Sydney, Australia. He was a member of the executive committee of the KDIGO and the International Society of Nephrology, the ISN, and is currently the chair of the ISN Education Working Group and a part of the core group of the ISN's Advancing Clinical Trials Initiative. He is also the scientific director for the DOPPS, the Dialysis Outcomes and Practice Patterns Study Program, and he has published his research in over 300 papers in index journals and lectured in more than 40 countries. He has been featured in a series of ISN podcasts covering the diverse topics related to the field of nephrology and current issues that impact nephrologists around the world. Professor Pecoits-Filho will be speaking to us on improving CKD quality of care. And with that, Professor Roberto, I welcome you to start your presentation. Thank you so much for being with us today.
Thanks, Amar, and thanks everybody for joining the session today. I want to also thank KDIGO for inviting me to represent the group that participated in this controversies conference last year in Berlin. And I'll just get started by saying that this topic today is extending a success story. Those are the meetings that KDIGO has organized around chronic kidney disease. So the initiative started almost 20 years ago, when the consensus for the classification was created and modified later in 2009. And there's been more focused meetings in Barcelona and Amsterdam. And this talk will be based on discussions that we had in Berlin last year. Also important to let you know that the content of this meeting would feed in to the new guidelines for CKD management, which will be in public consultation later this month, and with plans of publication for the end of the year. This is the paper that summarizes the discussions there. As you can see here, it's an international panel of experts that gathered in Berlin to talk about trends and perspectives in improving quality of CKD care. As I said, this information that will be discussed will be partly helping to update the KDIGO 2012 CKD guidelines, which is shared by Adira Levine and Paul Stevens. They met for the first time last year. As I mentioned, public review will be out in the coming weeks, and publication is expected at the end of 2023. So back in last summer, we met to discuss and examine best practices for improving the precision of CKD diagnosis and risk stratification. Also review the approaches to managing complications of CKD. We talked about safety and quality of life. As part of that, and I'll leave that to the discussion today, we revisit the importance for accurate diagnosis, not only of CKD, but also the causes, including some methods like imaging, biomarker, biopsy, and the new technologies in the assessment of kidney function and damage. And I think at the end of the discussion today, we might be able to have a broader understanding of the impact of CKD and how to mitigate those problems to improve outcomes in patients with chronic kidney disease. There was also a discussion about best clinical practices and research needs, and they are all summarized in the manuscript. So here's the group that participated in the discussion. It is important to highlight that there were representatives from Africa and all continents. And this has been an emphasis of KDIGO's initiatives, just to make sure that the group is representative. So let's start reviewing about what is current recommendation and what is new about how high risk patient populations identification. So what you see here in the top of the slides is actually the typical list of conditions that increase cardiovascular risk and chronic kidney disease risk, with the three main players here being diabetes, hypertension, and cardiovascular diseases. But it is very important that we understand more and more that understanding the causes of CKD beyond the diabetes and hypertension, especially as new treatments for specific diseases emerge, and also when we start screening patients in regions where access to kidney care were not present until recently, including some regions in Africa. And you see here several high-risk individuals that are more peculiar to your region, like low socioeconomic status, preeclampsia, toxins, HIV. Now, moving to CKD screening, also I think our perception is that the screening for CKD has not changed really that significantly. So estimated glomerular filtration rate based on serum creatinine remains a very useful screening strategy. And more and more has been emphasized that coupling this with a urine test to detect albuminuria or proteinuria is very important. It is noticeable, however, that the combination with creatinine and cystatin C might improve performance of the estimation of GFR, although we need to be conscious of the additional cost that represents. So usually for low resource settings, cystatin C has not been recommended to be applied broadly. The staging classification remains the same, and the definition of CKD with a GFR below 60 and or an albuminuria higher than 30 milligrams per grams remains currently the base for risk stratification in those patients. It is very important to assign categories to identify cause and make sure that you combine urine assessments to have a complete view of future risk of progression of kidney disease and cardiovascular complications. So here's just a summary: a urine test to check for kidney damage and a blood test to check for kidney function remains the most efficient way of screening and diagnosis patients. Here you have UACR, but starting with eGFR, very important that tools to identify risk based on GFR and also to help you to calculate the estimation of GFR are important, and they are very broadly accessible. Also on the right, you see, some color map that I consider very important to be applied broadly, including at the level of primary care to identify the level of risk. Now, moving to urine evaluation, I think in most of the developed world, the UACR, urine albumin creatinine ratio in a spot urine is considered the best way of assessing albuminuria. But as you can see that the dipstick can be a very interesting way in low resources area to really identify patients at risk. This is a study, for instance, that you can see that using a dipstick, you have a specificity of 88% for diagnosis of CKD 98% for A3, meaning the higher levels of albuminuria are very accurately detected by the dipstick. And I advise that, you know, if there's low resources and limitations to implement UACR, that you implement dipstick as part of the CKD risk stratification. And this is the famous KDIGO heat map for CKD, more and more used. And in the next version of the CKD guidelines in 2023, it will continue to be exactly the same as you can see here. I'm sure that you're very used to this heat map and using in a daily, in your daily practice. This is something else that maybe is less utilized, and in the new guidelines and in the discussions that we had in Berlin, it caught a lot of attention, and that's adding the kidney failure risk equation to the risk assessment. I think, and I use it all the time. It has some advantages, although the blood tests, the urine tests, and also the data you need to calculate the kidney failure risk is the same as in the KDIGO stratification. It is a bit more reliable in advanced CKD when you combine both approaches. And the way you inform patients and inform decisions, and in a way that you can say there's an X% of risk that you'll be in kidney failure in 2 and also in 5 years, I think it's a very patient-centered tool, and it helps in the planning for when to plan for preemptive transplantation or vascular access or modality selection. This comes from the diabetes guidelines, but I think it's very useful also for CKD more broadly. This stepwise approach to managing patients with CKD from diabetic causes or not follows this concept that the first thing to do is to actually implement lifestyle changes. On top of that, you have some drugs that need to be introduced and current. So I was just mentioning, you know, the lifestyle changes are still very important. Both healthy diet, physical activity, smoke cessation, weight management continue to be, and this will be included in the 23 guideline revision. Then this is for diabetes, but the first line drug therapy is applied also for non-diabetic chronic kidney disease. Both SGLT2 inhibitors and RASi inhibition should be implemented to most patients that tolerate, and metformin for glucose control in diabetic patients. And then you have at the bottom some other areas that you need to manage to control comorbidities. So a lot of important drug therapies were introduced in the last few years, particularly SGLT2 inhibitors, but also non-steroidal MRAs as new treatments to avoid progression of chronic kidney disease. So a lot of evolution, and I think the challenge will be how to increase access to those medications and improve implementation of therapies. This is a bit controversial. This comes from the KDIGO guidelines for blood pressure control. In the center here, you can see the non-pharmacological therapies, and in the green box down, a new target for systolic blood pressure of a lot less than 120 has been proposed in an individualized manner for patients that can tolerate. They might have benefit in especially reducing risk of cardiovascular events. So more aggressive blood pressure control is a new recommendation that you see here. And similar, I think, with safer anti-diabetic drugs, there's been more and more opportunities to control HbA1c closer to the targets of 6.5, but still for some patients with very advanced chronic kidney disease, especially those that cannot tolerate several drugs for diabetes control, you can actually have a flexible management and tolerate higher A1Cs. Now, one additional thing that I think is very important and new in the discussions that we had, and this will be introduced in the revision of the guidelines, a very strong message of the importance of identifying symptoms related to chronic kidney disease and treating those symptoms that you can see listed here accordingly. I think in the past there has been not enough emphasis on the importance, and patients consider this a very important and a priority in things that they expect from treatment is really reduce symptoms and improve quality of life. So the message from KDIGO now comes stronger, and I hope that we can find ways of recognizing symptoms in clinical practice and treat symptoms more aggressively. And finally, this is a slide that summarizes the more of an approach to quality of care for CKD in three main pillars that I think could be very helpful from a high level to implement CKD care of high quality. One on the left is really put a lot of value in looking at the models of care. More and more emphasis has been done in diagnosis CKD earlier and staging and prognosticating to all patients, including defining the cause for CKD. So this is an important pillar for model of care. Sharing with patients and other stakeholder decision also it's an important thing. And one thing that is very challenging, although very important, is the integration of CKD care. When I say integration, I'm talking about a good communication with primary care physicians and specialties like diabetology and cardiology. And finally, if possible, multidisciplinary care, since to add value to the quality of care in CKD. As I mentioned before, the other pillar is the non-pharmacological care. And I think this is a very cost-effective way of providing quality CKD care programs for exercise, nutrition, mindfulness, and peer support. And on the right side, try to implement and increase access to medications like RAS inhibition, SGLT2 inhibitors, and non-steroidal MRAs becomes another important pillar with strategies to optimize the medications and individualize pharmacotherapies. This is my last slide, and it shows part of the discussion that we had in Berlin, which I think is important and defines how perhaps CKD investigation might be in the future. This is a figure of the paper that we published in which characterization of patients with chronic kidney disease through a deep phenotyping, including, when possible, biopsies, lab values, imaging, and if indicated, genetic testing are important strategy to characterize the patients. Also, if possible, all of this data should be integrated in electronic systems. I think that would help a lot in terms of taking advantage of the data you collect. And this patient population that is better characterized might be better stratified for optimal treatment with patients with higher risk, deserving more aggressive and thorough therapies. Finally, it is important that this model is going to be implemented in clinical trials too. So we can expect in CKD care in the future a little bit more of a personalization of care that would need to be implemented in care of these patients. That's what I have to say. Thank you very much for attention, and I think we have some time for a discussion now.
Thank you very much, Professor Roberto. This beautifully just encompassed everything that we need to do for patient, and especially individualizing care. So thank you very much for that presentation. I would open the floor for a Q&A. You could use the regular chat box or the Q&A chat box and post a question for Professor Roberto. And also, if anyone of the attendees would like to ask him a question directly, please do raise your hand, and we would love to hear from you. The panelists can freely unmute themselves and ask Professor Roberto a question. Welcome.
Yeah, thank you very much for this. Good evening, everyone, or good afternoon, or good morning from wherever you are joining us. Thank you so much for your presentation. I'm just wondering how best we in sub-Saharan Africa can screen our patients. How do we screen our patients? Whole population screening is obviously very expensive, and suggesting to screen target groups like DM, we know that many of our patients with CKD is not really from DM. So what suggestions can you give us, please? Thank you.
Yeah. Thanks, Dr. Lassi. That's very nice to see you here after seeing you in the ISN meetings. I think you're right. I think the screening program in low resource areas need to be comprehensive, needs to be aligned with the resources that you have, and also needs to cover peculiar causes of chronic kidney disease that might not be that prevalent in other areas or geographies. I think that's the first question you need to ask. It seems to me that hypertension and diabetes continue to be two causes in which patients should be screened universally. But I would imagine that in sub-Saharan Africa, especially in areas where HIV, for instance, is very prevalent, that's another population that you might consider. One thing that I think is challenging is AKI. I know that AKI is an important cause of hospitalization due to toxins or other causes. Sometimes hard to diagnose and hard to follow, but it seems to me that there might be another one that might be relevant for countries in Africa. But of course, at the local level, it all depends on, how prevalent some of those diseases or conditions are. And for those patients, you can actually implement the program. As you mentioned, it is not really cost-effective to screen all population.
Thank you.
Thank you for your question, Prof. Lassi. We have in audience with us Professor Francis Frederick Furia. He's a senior pediatric consultant nephrologist at the Muhimbili National Hospital in Dar es Salaam, Tanzania. Welcome, Professor Francis.
Thank you so much, Professor Roberto, for this interesting talk. I'm just looking at the structure of care in sub-Saharan Africa, and my biggest concern is when you talk about the integration of care in this setting, it is not looking at the specialized care like the diabetologist, because here we're talking about I think there will people that are equivalent to physician assistants who are providing most of the care in the primary care setting. So I think that is something that maybe could be captured if you're looking at this particular setting. And I guess the other important thing is the fact that when you're looking at the care of patients with CKD, particularly those with end-stage renal failure, we might not have access to renal replacement therapy. And most of the patients that are attempting to go into renal replacement therapy, they will really incur catastrophic costs. And basically, I would think that when we talk about palliative care in this setting, whereas in the West, they're talking about patients that might not be able to support because of their state, going into dialysis. In our case, it is the cost. So I guess we might need to be looking at the cost as one of the factors that might be considered to put patients into palliative care. So I mean, these are the two things that I'm looking at, because the guidelines are they might not be really sometimes if they're going to be utilized, then they really need to look at when we look at the integration of care, then we need to be looking at what are the things that can be done for people that are not providing specialized care, but they are providing primary care in the setting of particularly sub-Saharan Africa. Thank you. But thank you very much for your talk. I really enjoyed listening to that. Thank you.
Yeah, I think you're right, Francis. And this conference didn't really go into details of chronic kidney management, conservative management, but there's an initiative by the ISN that really focuses on that, and it's very practical. So there will be a curriculum developed to support people on how to implement conservative care and palliative care, and that might be helpful. It will take a while for you to see that, but I think that's going to be a good resource.
Hello, Prof. Roberto. Elliot here. Elliot Tano, Ghana.
Hey, Elliot. How are you, my friend?
I'm good. I hope you are good also.
Yeah.
Yeah, and it's great to listen to you as always. So I think what I'm about to say is actually a comment, and maybe just riding on the big issue of the fact that since we are tending in our part of the world to see more patients come very early, the issue of course, targeted screening vis-a-vis universal screening, I ask myself, who is doing the payment? Because if I am to see an individual, and I'm coming from an individual point of view, and probably because we are tending to see our patients come in with CKD very early, and you tell them, listen, save X amount of money and decide to maybe check your kidney functions on X number of, or X frequently, let's say maybe once a year or after age 35 or 40, because most of our patients are getting CKD in and around after 40. Would that not be a good thing? Because it's still difficult for us to get our governments to decide to commit to healthcare in terms of, management of patients with kidney disease. But nonetheless, if you have individuals or you have people, or we are able to talk to people who will be willing to screen, let's say even a population, so we can pick those at risk. I mean, basic things, urine dipstick, and follow these people up. Because of all the things we've not been able to explain from our socioeconomic point of view, from our, of course, climate issues, from our herbal medications, drug exposures, and all of these, wouldn't that be more helpful to pick these ones up? Because unfortunately, if we all sit aloof, they come to us like they always come to us, where they're so late, and you ask them whether or not they can afford renal replacement, and they tell you no. So I've always juggled with this issue of, what do I tell an individual? I go out there to talk to people about kidney disease, and I actually encourage them to screen themselves. But then we talk generally about, come on, maybe we cannot do universal screening. I don't know what you have to say to this. It's actually a daily battle in my mind. Or else you might end up seeing these same people some years later coming in with, end-stage kidney disease, and of course they cannot afford dialysis. So I'm asking myself, maybe X amount of money every year vis-a-vis, waiting till you get kidney disease and you cannot afford renal replacement therapy. So that is the hallmark of our challenge in this part of the world.
Yeah. Well, first of all, Elliot, just wanted to let the group here know that you were present in that meeting as an African representative. It was a pleasure to have you there. And thank you for your contributions, bringing, this low resource country perspective. I think you're right. I think this needs to be, first of all, it's not enough to just screen. If you want to start screening, you need to really integrate some kind of comprehensive care that could or not include dialysis, but you shouldn't really, I don't think it makes a lot of sense to screen if you don't have at least, a plan. So this is an important thing, but not necessarily the plan needs to have dialysis. You could really manage symptoms and improve quality of life and prolong initiation of the need for dialysis. And this needs to be discussed clearly with the payers and governments, just to say that it is worth to do it, especially if it's an early intervention, and if you can implement the therapies, they are not that expensive. Even the new ones are not that expensive.
Yeah. Thank you very much for that. And just a follow-up. So with that, I have an NGO that sometimes we go out there and we screen people. The beauty is that when you go out screening, so some of them might not even know they have diabetes. Some might not even know they have hypertension, which are all major risk factors for kidney disease even in the first place. And of course, those you might pick with proteinuria. What I've realized is that when you pick them fairly early, like you also mentioned, it is not expensive, to prevent progression. Some ACE inhibitor here and there, some cut your salt intake, like you also mentioned in your wonderful presentation. Lifestyle changes, exercise a bit if you're obese. Those are not too expensive. And those, I believe that when we talk to them well, they can manage it. Nonetheless, probably the few who run into trouble, then when we are knocking on the government doors that, listen, okay, from what we know, these are the numbers that will end up this way, support them, then it becomes helpful. But when we sit and we probably don't do much, and then of course they also sit, keep on taking their painkillers and all of that, and then come to us later, then it becomes tough. Yeah, so it is one of the things that I believe that, would work. And like you also mentioned, in Berlin, these are some of the things we brought up because of the kind of patients we see in our part of the world. And thank you very much once again.
Yeah, can I make a comment to that? Roberta and Elliot, very interesting discussion. I think that the golden rules that we have in the World Kidney Day golden rules are perfect to use for everybody. Those that have early kidney disease, and for the normal population, they should know about it. Drinking water. I know many of my patients who have come in with slightly elevated creatinine and all that, and the mere fact that I take them back, I just recall one who is an oncology patient who came with impaired renal function. They sent him to me for him, just taking water, getting him to take 3 liters of water, and then creatinine came down. So these are the simple things we can do that don't cost money, and we're saving lives. Thank you.
That's right. Thank you very much, Prof.
Hello, good evening. I'm Victoria, a training dialysis nurse.
Welcome.
Thank you. My comment is I want just to supplement on what Dr. said about screening. According to my observation, by the time we diagnose end kidney disease, it is already late. Most people are asymptomatic. So I would also suggest we do regular screening because people are not aware, and also do outreaches to inform people about kidney disease, how it presents, what they need to do to prevent, so that we can mitigate the outcomes of end kidney disease. That's all I wanted to say.
Thank you, Victoria. We have 2 questions in the chat box, and the first is, what is the incidence and guidelines for prevention of pre-eclampsia, eclampsia, and pregnancy-induced hypertension? Is there a monitoring tool that enables other professionals to detect the probability of these patients progressing early?
Yeah, unfortunately, I don't have much to say here. That there's no ongoing guideline developed in the preeclampsia area for kidney in relation to kidney disease, and I wouldn't dare providing views from a hypertension perspective. Also, mental health, although anxiety and depression are among the symptoms that I show that should be screened for patients, treatment itself is not included in these guidelines. And I think this will be something that needs to be included in the future.
Thank you. We have Dr. Beatrice Bogo with her hand raised in the audience. Dr. Beatrice, can you unmute yourself?
Hello, good evening.
Good evening.
Yeah, my name is Beatrice Mogo. I'm a clinical nutritionist. And my concern was, according to the former speakers, we are talking of preventive measures. But according to the way we are, it's like nutritionists come last when we are coming to treatments. So how would we incorporate nutrition in the preventive? Because I believe if we can start with the patients, and I have gone through, I've seen through several patients in my experience. When we start with them, they go through several years. So I think what my other colleagues are saying, preventive is the key, and we should just embrace it. But please, let's just remember nutrition is key. Thank you.
Yeah, thank you.
Thank you.
It's different when you have an infrastructure to provide a dietitian in the multidisciplinary care, which is, most of the time is not really feasible. I think the main problem is that, if this is incorporated by a nurse or a physician, that this is, it's time consuming, and it disturbs the way that the appointment goes. I do think that we might develop ways of making a efficient nutritional advice program, really focus on things that are priority in a personal way. Some patients really don't need the full nutritional advice. It might be just protein restriction, it might be salt restriction, potassium in some cases, but it's not for everybody. So I think we need to really see how this could be done and develop programs to support that advice, so that this is not disturbing the daily practice for patients that deserve. Implementation is not that easy.
Thank you very much, Professor Roberto. I see you're responding to a question on the chat box. However, I was hoping you'd be happy to answer it live. This is a question from Dr. Azoel, and he's just inquiring if there could be a future guideline for managing health issues related to ESRD.
Can you say it again? Is it?
So there's your take on any future guidelines that would help in managing mental health conditions associated with end-stage kidney disease?
Yeah, not really. There is, although a clear need to identify, especially depression and anxiety in the new guidelines, but no advances in terms of advice on how to treat. Not a lot of evidence there, but I think we need to start screening in all patients with CKD, especially more advanced CKD.
Thank you very much. While we wait for a last question, I would just like to say that the Tanzanian audience attending tonight, anybody claiming CPD points, please find the link on the chat box. We will also have a video of this chat uploaded on our YouTube channel, the Africa Healthcare Network Fireside Chats, hopefully in the next 4 or 5 days. Professor Roberto, we would love to thank you for your time that you've given us this evening. This was a really lovely presentation, and it was lovely to hear your experience with your side of the world, and globally, of course, on behalf of the Africa Healthcare Network and all those attending. Thank you very much for giving us your time this evening.
Thank you all. Thank you very much.